Okay, thank you.
Thanks, Michael.
No problem.
Okay, good afternoon. Welcome to New York Medical College's Department of Public Health's National Public Health Week Speaker Series. I'm Dr. Mark Kittleson, Chair of the Department of Public Health. We have a very exciting week scheduled, starting today with Dr. Oscar Allen's talk. We'll be introducing Dr. Allen shortly. Remaining speakers this week will include Dr. Nancy Stamler, Progenics Pharmaceuticals, she's speaking tomorrow, and Dr. John Allegrante, Columbia University on Thursday. Yesterday, Dr. Howard Kippen from Rutgers gave an outstanding talk on air pollution. First, a few items to deal with. This is being recorded and we will post it on the department's webpage within a short time. I'll be sending that website into the chat shortly. This event is also sponsored in part by the student organization STUI, Student Healthcare Executives, led by President Brian Batista. I thank Brian and all the officers for helping make this event happen. STUI is very much involved in services to the community. I'm going to send in, I'll also type in the STUI website on the chat. This year they're working with Feeding Westchester, and they're doing a lot of great work with the Feeding Westchester for this spring. So we appreciate all the support that you could provide them. We are also, we're going to ask you that you stay muted, and if you have any questions, please type it in the chat box. At the end of this presentation, we'll hopefully have between 10 and 15 minutes Q&A. I'll be monitoring the chat and we can ask the questions. We're also being assisted by the Department of Educational Media with Michael Frankfurter serving as our IT specialist. Should there be any problems with this event, like a bombing, a Zoom bombing, we will end the presentation immediately and you will immediately receive an email with a new Zoom link. Thank you, Michael, for your assistance. Finally, we're trying to comply with our accrediting agency's request to maintain contact with our alumni. If you're an alum of our MPH or MS or DrPH, we ask that you consider completing our alumni survey. And again, I'll be typing those. There's one for the MPH and MS and also a survey for the DrPH. I'll be sending those in the chat. So before I turn this over to Dr. Denise Tahara, who will introduce our speaker, I would like to give Dean Robert Ambler, a chance to say a few words.
Thanks very much, Mark, and everybody. Welcome to our next event for National Public Health Week. And I hope you're all enjoying our special week in the field of public health. I can't tell you what a real personal pleasure it is to welcome our favorite son back to New York Medical College, Dr. Oscar Alleyne, who over the years has been a colleague out of Rockland County. He has been a student. He has been a partner on so many committees and initiatives and projects that we've done together. He's also now an alumnus of our school, but more than anything, he's just a friend of all of us. And it's just a real treat to have you back. You'll hear his bio in just a minute from Dr. Tahara, I believe, but let me simply say in a nutshell, Dr. Alleyne is the guy who runs the retail public health apparatus of this country. Aside from that, he doesn't do much at all. So let's all put our virtual hands together in appreciation of his being with us today. And ladies and gentlemen, I give you Dr. Denise Tahara with the formal introduction.
Thank you, Dr. Kittleson, and thank you, Dean Ambler. It's really my pleasure to introduce Oscar. He is, I'm going to give you a real synopsis. It won't even capture exactly how dedicated and committed he is to public health. Oscar is the Chief of Programs and Services for the National Association of County and City Health Officials, NACCHO, where he oversees a $46 million portfolio program along with membership and meeting services. He directs the implementation of programs and diversification of funding through external engagement, assists in creating partnerships for the success of the country's 3,000 local health departments. He leads NACCHO's national response to emergent health threats such as COVID-19, Zika, and natural disasters. Oscar has an experienced and demonstrated history of working at the local, state, and national public health sector. He began his career in governmental public health, designing expert system software for guiding responses to adverse water quality events at the New York State Department of Health. He joined Rockland County Health Department at the beginning of the West Nile virus outbreak, where he developed a model comprehensive educational and surveillance program. In his 15 years at Rockland, Oscar served as Director of Epidemiology, Public Health Planning, responding to and mitigating several major emerging health issues, including West Nile, anthrax, smallpox, monkeypox, H1N1, botulism, MERS, COVID, Ebola. He also is experienced as Planning Section Chief for the Disaster Medical Assistance Team, NY4, under the Federal National Disaster Medical System. He's skilled in epidemiology, health communication, population health planning and assessment, government, emergency preparedness, informatics, biosurveillance, and environmental health. Dr. Alleyne also served as president, chair, and active board member of New York State Public Health Association, which is where I got my involvement, and past chair of the epidemiology of the American Public Health Association. He's currently on the executive board of APHA. Go, Oscar. Oscar's community service is really too long to describe in a very short minute, as are his publications, and I will put a link to his information on the APHA page. Oscar is also a Freemason, and I personally, I love the fact that you're a Freemason. Sorry, it's just one of those things that I think is pretty cool. I think because the purpose is to make better men out of good men, and I think it's a really good time to be a Freemason. Oscar earned his DrPH here in health policy and management at New York Medical College. He has a master's of public health and environmental health and epidemiology, and I'm delighted to turn the program over to him. I welcome my colleague and friend, Oscar Alleyne.
Thank you so much, Dr. Tahara, Dr. Kittleson, Dr. Ambler, my colleagues, both alumni as well as current students and staff and faculty. You know, it's a pleasure to be here. And as was mentioned, you know, coming back home is always, it's always great because you get to let down your hair, figuratively and literally, and not worry about, keeping up appearances. And in fact, in speaking of such, most folks don't know, but when Dr. Ambler had really come into this region, in his capacity working with HHS, et cetera, that's where we had actually met. And we were part of this larger regional addressing for bioterrorism epi, and subsequently maintained our interactions over the course of time. So it's always a pleasure. I'm just going to jump right in because I know time is of the essence for folks, but I just wanted to, as we detailed this, this conversation, it's, well, how do we talk about what's been happening nationally, especially around COVID, and the organization that I represent, being formerly a local health official in the capacity of working for the Rockland County Health Department, to now being at the national forefront, addressing the 3,000 county city jurisdictions across the country. So we entitled this Our Path Forward and Building Resiliency with Innovation and Optimism. So to do that, I must always go back in time. And early public health is actually quite interesting because if you looked around the year 1799, one of the early health departments in America was formed in Boston. And predominantly it was formed to help fight the cholera outbreak, of which we'd had several in the course of time. Its first president was Paul Revere. Go figure. What is interesting about this, when they actually created this first board of health or local health department, the goal was to, in order to save lives from cholera, they posted signs. So health communication, community engagement. They held meetings. They led early public information campaigns to reduce deaths. And they also included the authority to levy penalties and fines for people who didn't follow the rules. So here we are, a great, patriot, Paul Revere and everyone else, as we know him, and one of our early founding fathers to a certain extent. And we still see governmental public health engaging in both the community engagement process, the education, and also the legal authorities to levy fines for people who don't think about the interests and the welfare of their communities and their society as a whole. So I shift because I want to illustrate something about the public health landscape. Most of you either lived in the Lower Hudson Valley region, so you may be in, or come from other areas, but specifically if you're in the New York area, you know that each county is what we call a home rule county, because New York State is essentially a home rule state, and those are the ones that are more so the teal kind of darkened color. Now, what this really illustrates is that when you look at governance across the country, each local health department or each state has a different governance structure to some extent. The majority are home rules, meaning that the local health departments are their own individual sovereign entities as far as local government is concerned, and they're on par with working in collaboration with their state health departments, state health agencies. In some jurisdictions like Florida, Georgia, Kentucky, it's centralized. And whereas when you look at the way the state runs the local health unit, it is actually staff, or they're part of the state-based system. And there are a few that are mixed. Now, I say that because the other side to this graph illustrates this slide illustrates another key point. When you think of health departments, the majority of them are small to medium, basically servicing populations of less than 500,000. And only 6% of the health departments in the country are what we call large. But ironically, as you can tell, because of large urban environments and populations, they tend to serve more than half of the US population as a whole. So with that respect, you can expect to find a health department that is a rural lean-in frontier community that has a staff of 7 to health departments like Los Angeles, Philadelphia, New York, which have staff size of 300 plus. Now, I say that because the other portion, if you remember from the Paul Revere slide, local health departments have this legal authority that is quite unique to our system. And what I mean by that is when you think about police powers, people think, well, police, it's public health and public safety, which is usually the law enforcement. Public health departments, and by virtue, their local health officers, also have similar police powers. Specifically, their powers are exercised to enhance both legislation and to ensure that policies are in place for the health and welfare of the public as a whole. The examples of this can be seen in how infectious disease are regulated, childhood vaccination for conditions for school entry, registration around how folks are able to operate restaurants, of course, isolation, quarantine, and other elements to that extent. Now, we're going to get to what you have already known, and I'm just going to make the assumption that you know this. The 10 essential public health services are the 10 commandments of public health. And that is what guides the operations of local health departments. Of course, we've seen the most recent update, which has a central key cog that focuses on equity emanating throughout all of these processes. But when you think what public health does, especially governmental public health, their role is to ensure that these essential public health services are adhered to, are operationalized, and are essentially delivering for the health and safety of the communities. So we know the toll of past pandemics. COVID-19 is clearly not the first time we've seen pandemics, whether we think about the Black Death, bubonic plague, smallpox, of course, Spanish flu, and you really want to go old school, the plague of Justinian in 541, 542. All of these illustrate this key point that we constantly know and understand. It is the linkages between human, animal, and environmental health that has to sync around the One Health. And this One Health really captures the fact that all of our actions and our activities are intertwined. And what we see with respect to emergent infections or diseases or even cures and vaccines have been as virtue of this syncing of those three in elements that we basically rely on the science to guide us. So I am an epidemiologist, so you are going to see some numbers and graphs. I warned you ahead of time that this is going to happen, but I will not spend an inordinate amount of time going through each detail. But I want you to just think about this particular slide and the key metrics that we are seeing as it stands, as it pertains to COVID and this pandemic, both the deaths, the hospitalizations, and of course, where we are with vaccines. And we've seen this death curve. We've seen the impact of first, we flattened the curve roughly around May. Then people decided they want to unflatten it. So we went back up in July, September, and then they really went for the gusto. And we saw this rapid increase to the end of November. And we're still seeing the unfortunate impacts of that today. The death rates, we would like to continue to decline. And our hope and aspirations is that really maintains this effort. Hospitalization rates, we understand around hospitalization has really come around some level of plateauing, and we're hoping we're not seeing a different direction with respect to that metric. When you look at just the first 7 days in January 2021, this is what we were seeing with respect to lab testing positivity by county across the country and hospital admissions that we also saw in that same time frame. Just looking at where that is now, we are not out of the woods yet, but it's a much different image with respect to lab positivity and hospital admissions. But we recognize that community transmission at the county level is still high. We are not out of the woods with respect to this pandemic. However, we see the general populace actually working counter to that understanding. And even likewise, as we think about where we stand around areas that are still sustained hotspots for communities of concern, we are still seeing that emanating, especially in the Northeast, in the Southeast, and other portions of our country. Now, NACCHO as a whole, we have enacted several programs, and by virtue of being the chief program officer, my role is to really try to both be an executive leader around what are those technical assistance options to really support the local health departments across the country. How can we amplify both their voices as well as ensure that there's funding that's provided that supports them at their local level? So we've been working on projects specifically around building the workforce capacity around healthcare and other settings to support local health departments. We've operated within this Project First Line, which is really focused on building infection prevention and control training curricula to local health departments as well as healthcare professionals in a peer-to-peer mentorship approach. We've really focused on providing assistance to rural workforce because they have been hit quite as extensively as our urban environments. And we also recognize the need to balance the environmental health activities to that extent as well. There's significant work around ACEs, adverse childhood events, as well as suicide prevention. And the whole reality here, when we think about the role of adverse childhood experiences, that there's a value for putting money in programs and dedicated to the infrastructure to ensure we address the larger capacity that we're seeing at local level. There's a significant role around disabilities, as well as addressing issues of vaccine uptake, which I'll get to in a minute. And in all of these particular programmatic areas, I've highlighted just a few of roughly about 70 to 80 different programs that we work on, but really try to identify what we're doing and how we're able to drive this agenda forward. And that is not without the understanding that the social determinants of health continue and are clearly shown as to be a significant impact on the lives and health, and the why we need to focus on both the upstream and downstream elements when we're thinking about both COVID response and resiliency as a whole. Now, I say that because this is where the data epidemic comes into play. The reality is, before this pandemic hit, we recognized that there were significant deficiencies and deficits in the data and informatics needs for local public health departments. They were not included in the Affordable Care Act infusion of dollars when electronic health records were deployed and really championed. Local health departments, and as I would say, were left at the side of the super information highway carrying a bus pass, an expired bus pass at that. So when you think about the role of having interoperable systems, we recognize that quickly this pandemic taught us that there's need for better data, whether it's data around racial and ethnic disparities, even the ability to create tools that can help us around case ascertainment, case contact tracing, and even things that are relatively operationalized that we can see use. And we've had to realize that several partners, such as MITRE, who developed a system called SerAlert that allows our membership to really take an open source tool to help them in managing their contact tracing efforts, which of course shifts to the element around the community and what we learned about vaccines and vaccines presence and just beliefs, knowledge, and understanding were that, especially after the heels of the Operation Warp Speed, that Americans wanted a vaccine that worked versus one that they perceived to be rushed. And that's where efficacy was really pushed as that element. And with that, you think about the tools. Now, these are tools that the private industry has and others seem to data mine, but have not necessarily been at the forefront of getting the access to local health jurisdictions. So I show you a graph here of mapped out resources that identify by census block communities and populations who tend to be on the avenue of being hesitant for taking vaccines or anti-vaccine for that effort. So you can think about, well, if we have this data, we can be able to use it as we both plan for vaccine hesitancy planning at the local level. And of course, or what are the tools and the dashboards that are going to be able to tell you what targets you hit around meeting your vaccine allocation, your vaccine distribution, and where your timelines are for hopefully accomplishing herd immunity. Because all of this said, we now had to shift into not only addressing this pandemic, but explaining to the general population, how do vaccines even work? How are they approved? You know, what are the world standing on the several vaccines that are being developed? What is the difference between a phase 1, phase 2, phase 3, and emergency use authorization? And where are the several vaccines across the country and or the world to that extent? And then how to even explain to the community what are the different processes that you can do to develop a vaccine. And then, of course, the ability to really hone up your training and understanding to explain mRNA vaccines and why that's different from other types. And then, of course, what are those issues around ingredients and addressing things of concern and really coming back to even the salient points of our social determinants and acknowledging that there's a significant amount of historical abuses, disenfranchisement, and medical apartheid issues that we cannot forget when trying to address these particular elements. So for example, whether it's the utilization of Henrietta's lax cells for advancing medical history without any acknowledgement of that to Henrietta or her family, what as we know about the syphilis experiments or the lack of provision of vaccines in Tuskegee, and even further back when you think of Dr. Sims, who was the American gynecologist who performed, he and others performed all of their experiments on African enslaved women because they felt they had the mentality that African women did not have the same degree of pain threshold as white women, and therefore they were able to conduct very atrocious experiments on them for the sake of science, and of course without hella care for their bodies and their own mental impact. And we've seen the same, of course, with respect to traditional indigenous populations, as well as Latin American populations. So there's an undercurrent of why the local health jurisdictions and the stakeholder engagement and community engagement was going to be important, because all of those things tied into the vaccine hesitancy and the mis and disinformation that we've seen and had to address, whether it's communities of color or just the general information about messaging and getting that clear guidance. And we know another scenario is how to interface with the elected officials. We can't tell you how much times we've had the impact of local health departments pushing out a particular message addressing COVID, and you have elected officials stand up and saying the total opposite. So looking at the vaccine distribution case study, you know, these are important messages to ensure that both the community, both the sectors, the elected officials and the health officials are in sync around communicating community-based strategies for vaccine dissemination, as well as establish interactions with the public-private partnerships. Now, I say all of that because the local health departments have I would probably say it's probably exquisite is probably the better word I want to use, role to play with the immunization roles. And I'm going to pause for a minute because this is an old school slide, and forgive me, and I'll explain why it's old school slide. It's the jelly bean slide that describes the public health system. And whether you look at you being a public health agency, local or otherwise, and the various connected neural networks, the connected jelly beans essentially illustrate of how well you have to be as a community health strategist and the health department level to interact with all these particular agencies. But when you think about the role of immunization services, our public health departments, on average, provide about 88% of childhood immunizations as well as adult immunizations. So when you think about the work that we were performing in the local health departments, vaccine hesitancy and lack of confidence were always issues that pointed to significant barriers to be addressed. So our own programs in the national agency, national organization to support local jurisdictions was around increasing participation, evidence-based strategies, and really affecting a pro-vaccination campaign. And all of these illustrated how we can really try to address vaccine hesitancy and increase confidence. And the role that I can tell you we played at the outset of the response was to be both in the Emergency Operations Center. So I sat in the Assistant Secretary's Operations Center. We liaison with CDC's operations, and we tried to both provide multi-directional efforts with what's happening on the ground and what is necessary so that the federal agencies understand the better policies and guidance need to be reflected of our community and our members' needs. I talked about data. I talked about the fact that, the vaccination programs, that the reality was as follows. In October, the state submitted their plans to CDC, and their plans varied. Majority of them had no visibility to their local health departments. In December, the vaccines, or 2 vaccines, got approved, and then local health departments had to implement several of these plans. So you had a problem of where things got essentially upheaved in an effort to really understand what strategies would come into play. And as you recall, things were much different in the beginning of the year versus where they stood now. But still, local health departments endeavored to look at innovation, look at ways to both incorporate better guidance in both how they registered individuals, how they plan for vulnerable populations, how they focus on school reopenings, and as well as other elements for training and education. We conducted webinar series where we highlighted those best practices. We've actually enacted several elements to show where those COVID response efforts were best met and the activities that were also impacted from regular immunization as a whole, and really focusing on that community health strategic role in building a safe and healthy practice that allow communities to better have informed decision-making for COVID vaccines. And I say all of that because the reality is there's a red flag when it comes to equitable allocation. So this is why it's important for us to look at all of these efforts, but try to strike the balance and maybe change that red into a little bit darker, a different color to hopefully addressing the insurance of equitable distribution by consistent messaging and all of the above imports that we found as it pertains to vaccine as a whole. So I can probably talk all night long about the local health, the drive-through clinics, the innovation practices, the ways they've integrated both GIS and community integration around social vulnerability index, of course, the work with the retail pharmacies, the health clinics, the utilization of both the profile and the dashboards. But I really want to strike this particular tone as I wrap up my remarks. I'm going to pause here to really reflect upon the health status of the health departments themselves. Notice my jelly bean slide has changed into a graphic that actually shows they're not jelly beans, they're people. The workforce has been so remarkably under stress from the first onset of this pandemic. There are health officials, who have been working nonstop. And when I say health officials, I'm speaking about all related staff. The capacity has been crazy. The need to surge and address both the needs from both tracking and tracing to vaccination. And we've seen a shift. The attack on science and public health was of significant concern. And the value of training as the support of both the wraparound services and the mental health, both for the responders and the communities in which they serve, really tells us as to why we need to look at the human aspect of what we do and who we are as we move forward. We know that the landscape says that our membership came to public health to altruistically save lives. We've seen several, if not hundreds, of them leaving in the wake of attacks, harassment, and even death threats. We see this has had an impact, and we recognize we're concerned about the institutional support and the knowledge that we will lose if we do not stand with public health moving forward. And we've seen this because we know from looking at administrative preparedness from the past, looking at where we stand of the work that's been put forth, our funding and the way public health has been supported has been minimal. But now we recognize the new infusion of dollars gives us an opportunity to look to the future, to really build up the practices, the elements that are going to really drive us to become more ready and more resilient as we think about what are those steps that are going to be necessary to allow us to respond to recover from public health emergencies. So I tell you this from both an academic perspective and as a public health advocate, especially governmental and local public health. Our future is now. There's diversified means of funding that we need to look at. There's public-private partnership, both with the academic, business, and other community members. There's the workforce that we can build through both strengthening the areas that have been deficiencies in the past, and the advocacy and cross-jurisdictional and technology support. And of course, I wouldn't be happy if I wouldn't say the benefit of looking at local acquired and reported data. Now, I end with this particular graphic for one last reason. If you look at the purple, which really speaks to the immediate mortality and morbidity of COVID, irrespective of where we are in the different ways, but that's really what we are faced with. We are hit with this pandemic, which has supplanted and pushed up everything else downstream or downwind so that we focus on this, which tells us that we have the other elements of those urgent non-COVID conditions that are also considerably going to be of concern and focus for our response, which then brings us to the third particular element, that of the uninterrupted care that has been sacrificed from the virtue of those chronic conditions, whether we know the heart disease, the cancer, the diabetes. These are issues that we also need to maintain our vigilance. But the most striking is that of the social, behavioral, the mental health, the economic injury, and the burnout across the board that we need to be prepared for. And we need to really holistically approach from the perspective of what we can accomplish and where we need those skill sets on the ground, because seismically, we are going to see the impacts of this from years to come. And that's why it's important for us to both consider the role that we play, the opportunities that we have before us, and without anything, please make sure to thank your local health departments. Thank you.
This was outstanding. Thank you very much. Thank you, Oscar. This is great. If you have questions, you can send them through the chat, and I'll also give a chance for people to raise their hands. I've got a quick question to ask you. Earlier, before we started, you mentioned that you were in contact with the White House. Can you explain what you have been serving, what role you've been serving with the White House, or how has it been advisory? Can you tell us a little bit about that?
Sure. So the public health departments, or I should say the national organizations, represent what we call the big four. So there's the state health officers, there's NHO, there's the public health labs, and there's the Council of State and Territorial Epidemiologists. In any capacity, when there's a national issue, pandemic or whatever, we get called. So I'm a liaison with respect to the capacity of really focusing on what is the response, what do our members need. In fact, right now we are engaging in a survey with CDC to address and assess the mental health capacity, or I should say response to all of the public health workers. So we have a sense as to what they've been experiencing. Sampson. Now, with that same framework, especially being a national leader, we interface quite extensively with the congressional leadership, as well as within the administrative leadership as well, to some capacity. The last administration wasn't as well open to that extent. Previous administrations have been, and this present administration has actually been working with us on a bi-weekly basis, where a weekly and a bi-weekly basis, where we meet with them, especially with their COVID-related, task force leads, to really address what are issues that we're seeing, and giving them both feedback on their activities and their I would say, briefings to the extent as to things that are coming down the pipeline. We've always really implored that we be involved in pre-decisional support. So if you're coming out with guidance, give us. We at least try to rapidly provide feedback with our subject matter experts, with our local members and others, to say, well, this makes sense or this is a load of crap. So that's the capacity in which we've been working and really trying to advocate for governmental public health, having a seat at the table, and really managing those particular relationships so that we at least work to the benefit of ensuring that the collective voices are being heard.
Okay, that's great. Yeah, thank you. Are there other questions? Why don't you can just unmute yourself and, oh, by the way, I just want to mention while you're thinking of your question, on the chat, I've listed the various links, for if you're an alum, please consider filling out the survey, as well as information for Stewie. Also, Michael Shakarjian has shared with us some of the stuff that our sister programs are doing in physical therapy and speech language this week as well. And there's a link that you can look and see what they're all doing. So if anyone has a question, why don't you unmute yourself and ask the question?
So I'm going to get started if you don't mind.
Sure.
I'm going to take the opportunity. Thank you for an outstanding and informative presentation. I have a lot of my students here, so I'm delighted that they came to really get a real dose of what is public health, especially those who are getting ready to graduate. So thank you for that. One of the things that we've been talking about pretty much nonstop is the issue of messaging, especially from public health, and literally the poor job we've been doing. And I think some of your slides sort of really reinforce that point. Could you talk a little bit about some of the strategies that have been successful that you have had your organization work with? We know that it's a diverse population, and we know that different messages meet different people. However, anti-vaxxers seem to be getting it right in terms of their impact. Can you just talk about some of the strategies that you use, or you've been working with you've been telling the 3,000 health officials who you're working with, that the students here, because some of them are currently in public health and the rest are going into, that they could consider integrating into their own the practices or organizations where they're working and helping in their communities?
Sure. One of the things we've actually been stressing, and that's both to the federal partners at CDC as well as to the members, which the members are pretty much know, is that we have to leverage better ways of engagement. I think one of the critical mistakes that we as public health did, especially the anti-vaccine groups, that we ignore them without necessarily providing a strong message, because we figured that common sense will prevail, and they were a quote unquote minority to some extent. Now, we know that because we saw the increases of vaccine preventable diseases like measles, mumps. I remember having a mumps outbreak in Rockland with about 300 cases. And I'm like, how is this even possible? Sustained for too long a period of time. And of course, we've seen issues going out west with similar types of activities. So they were always there. They were always pushing their message, but, kind of ignoring, like, yes, they're a fringe group. No one's really going to listen to that. And then COVID hit. And then we saw, of course, with the advent of social media and in respect to that degree of engagement, how rampant and how rapidly these types of messaging spread, where from our lens, the tools that we had were totally inadequate and unprepared. As we would say right now, you're not going to change behavior by creating a billboard. Billboards don't work unless you're a Liberty Mutual insurance person, right? But the reality is, in order to affect change, what we have seen with the feedback from individuals, of course, they get their information from their particular sources. And we're never going to win the argument about which which, political source or which scientific source is the more valuable. What is really going to be helpful is in targeting and getting those ambassadors, those individuals who are the trusted entities that folks listen to. And I don't mean that it's the religious leaders, et cetera. Sometimes they don't want to hear that. It's within the communities. It's this person or this personality. Those are the ones that we need to really affect change and target and provide with the right messages, because in fact, they amplify out and others tend to listen to that information and their trusted sources, and they feel more comfortable. I can tell you that I experienced this throughout the entire pandemic, because I've, in my Facebook page, I've been consistently providing, updated science and just sticking to the science and sticking to the messages. And I have folks from all sides of the world. And ironically, I see the folks who, in the same breath would attack Dr. Fauci to my face. By the same token, they're like, well, when you say it, we understand. I'm like, I'm not saying anything different than what he's saying, but you have put him in a particular lens that you don't want to listen to anything he says because you associate him with your political particular, perspective. So it's important to, when you identify those groups or those individuals, and if you're going into this kind of community engagement side or public health side or messaging or communication is going to drive everything we're looking to accomplish better. It's not the solution, but it's going to help us as long as we learn how to better understand how people gain information, how they digest it, and how they give it back. And that's really what's going to be very helpful when you think about the strategies that are going to be very selective and hopefully help, successful.
So one size does not fit all.
Absolutely not. Absolutely not. Word is so simple. Sorry, Erica. No, you're fine. Go ahead.
So my question, in the beginning of your slides, you were talking about how, there's a lot of variance in local health departments' governance, how states run their health department. One thing that I really thought was curious about this whole pandemic and the response to the pandemic, everything seems so disjointed. And to me, it felt like, how people were saying, like, going into this pandemic, it's like going to war. And like, to me, it felt like you want a really like well-coordinated, like central focused like plan and strategy, kind of like how the military operates, in the sense that everything kind of like fits and knows how to move smoothly, even though it's very large and there's like multiple fronts of battle, so to speak, which you could compare to hotspots. Do you see in the future of public health in this country more of like a kind of centralized, coordinated push, not necessarily the decisions on like the local level, but just better communication, better like information sharing and coordination?
So the irony in all of that, we went into this thinking that's what we had. Our experience that we have had both with SARS, MERS, Ebola, West Nile virus, Zika, our experience has always been from governmental public health. We had one or two groups that we interacted with who centralized the response from a federal level and helped guide, quarterback, for lack of a better word. CDC was always that group for us. We trusted CDC. We knew what CDC was able to provide. We questioned where we needed to question, but we were able to engage. So whether it was H1N1, West Nile, all those elements, we all had to develop plans. So every health department had a pandemic plan of how they were going to execute it, how they're going to respond, how they're going to identify vulnerable populations. If it came to mass vaccinations, every health department in the US had a plan. Where those plans fell away was when the federal entity or the federal enterprise basically said, we're not taking any responsibility. You do it on your own, and shifted that role or that responsibility to the states. Now, here's where things got a little screwed up. When you put elected officials in charge of making public health decisions, you're always going to have a problem. So in that regard, we saw governors doing one thing, others doing another, and essentially every playbook that we had got thrown out the window. So your observation is 100% accurate in recognizing that the need, the disjointedness of the response was part of the downfall. And we would tell you that we agree with that because we bemoaned, we belabored, we were concerned about the lack of voice the CDC had, even with the leadership that wasn't necessarily striking at that, and how this cult of personality essentially led to some very bad decisions. And I'm not speaking CDC alone, but across very bad decisions that really had us running behind versus being ahead. So moving forward, and this is why I think this experience and the continuation of the experience is one that strikes the balance as to how do we reframe what governmental public health response looks like? How do we ensure that both with the infusion for the American Recovery Act and all these other dollars that have come into play, that we're adequately infusing both the infrastructure and the human and technological means to create resiliency so that the next pandemic, which will occur again, does not disjoint us by virtue of a cult of personality, but that we have established systems that were well-oiled, well-practiced, well-tooled to really get us through, any type of response that has a similar perspective.
That was a good question, Erica. Very nice. Any other questions? You can just unmute yourself and ask. This is great. Yeah, go ahead, Fremont.
So we've seen other countries in Europe and in Asia, like Taiwan, they handled the pandemic way better than the United States did. So I'm just, for me, is it a population thing that we just couldn't handle and they had like a lesser population that we had? Like, why can't we just like take a step back and say, oh, Taiwan, South Korea, they handled it really well. Like was it what Erica said, that decentralization of handling the pandemic? For me, if I see someone doing something better, I'm like, okay, I'll do it your way versus what I'm doing is just not working.
So I would tell you that two things. The irony in all this, Taiwan, South Korea actually learned from us as far as how to do things well. And then we totally just dropped the ball with respect to the nationalized response. And I say this for another particular key element in my answer. One of the things that we've seen from especially the South Asian and the Asian countries, which is so different from the American lens. And this was if any of you have ever seen the movie Contagion, one of the favorite movies that that as an epidemiologist, I love, probably saw it too many times. But when that movie first came out, one of the striking things that I observed from that was the fact that when individuals left that movie, they were concerned about touching surfaces of the doors, and we actually saw the normalization of wearing masks. Now, before that, everyone looked at anyone with a mask in the US as, oh my God, you have something contagious, stay away from me. Whereas in the Asian countries, to that extent, in the Eastern countries, we saw that mask wearing was commonplace. It was, what can we do as a community to protect other people from a potential of infectious, illness or fomite, transmission. So the scenario is, when you think about what the Southeast Asian countries that you had mentioned had done well, they were able to both mitigate with lockdowns. They were also able to mitigate with testing and mask wearing in a ways that was centralized, was followed and adhered to. And they also prepped in their response for ensuring the health capacity of the health system wasn't as overwhelmed, or at least try to build and invest in those health systems different to what we had done. Because now, instead of having a national federated response, we had 51 different jurisdictional responses. And as you saw from my slide, technically those 51 jurisdictional responses are even filtered out even further. So the what went wrong and the lessons learned, I think I can probably spend an hour or plus just describing, but in reality, the value has always been that you are supposed to look at what is working well and how you're able to adjust and pivot. The difference, I would say, in the Asian countries versus America, we did see with our large biodiversity, a shift in what we learned about COVID. So COVID, in a sense, did hit the European countries like Italy, and that's really where we got most of our information from. What happened in Spain, what happened in Italy, and then spread through Europe. But once it hit the U.S., our biodiversity, I think, give or take how you want to look at that, I think further amplify this petri dish that this virus essentially enjoyed. Of course, with the tenacity of our American. I'm trying to find a polite word here. Oh my gosh, I don't want to say our quote unquote, our desire to be American and to be right and wrong at the same time. I think help, foment the spread in ways that we're seeing folks fighting against wearing a mask. Masks became political. Folks, fighting the distribution of cases as if, it only affects fat people, it only affects Black people, it only affects Latinos or minorities, so it's not an impact to me. We're still seeing these types of this mentality, which unfortunately is very difficult to cut against. But when you think about this larger construct of how that amplified as a national type of response, there was no way we had a chance and a chance to be as successful as the way South Korea and other parts of the world were successful. And that's just being real.
Oh, thank you so much. Yeah, thank you so much.
There's a question in the chat.
Yeah, Dr. Shakarjian, did you want to ask bring up your point?
Sure. Oscar, nice tie. Nice on this discussion, can you see how the local health departments can better manage what we may call those captive populations like nursing homes and prisons that were poorly served in New York and New Jersey and elsewhere?
Sure. And I normally would wear my disease bow tie, but I didn't today. I have a COVID bow tie, but I don't wear it. Didn't wear it for this session. So, it is very interesting because this talks to my earlier point around looking to the future. The way we conducted governmental public health has to change. And we talked about that before, where it says, well, change is with ACA, everything is going to be pushed out to the FQHCs or the medical homes. And that never really happened because safety net provision by governmental public health actually increased under the ACA to that extent. But when you think about things such as correctional health, refugee, immigrant, migrant health, these are all core public health programs and public health activities. Now, what's going to be important to really understand the way we provide these types of health strategies and how they're funded needs to change. Because right now, here's what it really looks like. Feds, the Congress says, we're going to allocate this amount of money for I'm just going to say, toe fungus. I'm just going to be very ridiculous, toe fungus. And that money goes to CDC. CDC says, okay, we have $5 billion for toe fungus. We're going to give that money to the states based on population. And basically 64 jurisdictions to 50 plus states and a few cities that are large, et cetera, they can handle the money. Then the states are then said, okay, now we're going to take the money and we're going to decide by our, what are we going to filter to the jurisdictions? And maybe some cases, you as a jurisdiction will have to apply for it after for reimbursement, or other times we give direct funding. So that kind of paternalistic approach is a problem. We need more direct to the jurisdictional funding, and we need less categorical funding, meaning investment in a public health fund as a whole versus investment in a particular disease. Because once you invest in one specific disease, you then have the balances of battles, right? I need to push for HIV. I need to push for STI. I need to push for hospital-acquired infections. I need, so all of these battling elements don't do anything because at the ground level, the community is not saying, well, I have this and not this. They're like, I'm just have poor health, or what can I do to address my health outcomes? So whether it is in those sectors, as you mentioned, looking at correctional health, integrating better, having a better system for both direct funding and diversified funding so that we have the resiliency to build in both a as we would say, a health infrastructure that is not just primarily based on one entity. A health department can't do it alone. When I was at Rockland, we had 130 people, okay? 130 people for 311,000 in the population. There's no way we were going to accomplish everything. So that's where the partnerships come into play. The nursing homes, one of the reasons why we're training nursing homes and healthcare sectors on how to do better infection control. Because if we teach them, downstream, we don't see the issues upstream. And likewise with the engagement in school-based populations, as well as, camps and all of the businesses, communities, they recognize now, and as I've always said, when people say, well, we need to reopen at the time, we say, yes, we need to reopen in the middle of a pandemic, but we need healthy people to reopen the business. We need healthy people in every step of the work that we do. Even if you're in the business of dead people, you still need healthy people to pay you to bury the dead people, right? So these are the elements that are going to be important as we think about how we restructure the public health infrastructure, that we're not just speaking about healthcare, but we're speaking about the entire, rubric of public health in a way that allows us to use innovation as well as data elements to really become better at our outcomes delivery.
Can't argue with you on that. That's great.
Thank you.
And let me ask a question. Unrelated to necessarily your presentation, but you've had an MPH, you have your DrPH. Was there, as you reflect back on your education, because there are a lot of students here, is there one course that you think, boy, I should have taken that a particular class when you were a graduate student, that you sit now thinking, boy, I was really, I should have taken such and such a class?
So I have an answer for that. And I'm usually, being in New York, I'm very direct. And I've said this in several scenarios before, and I know the dean's not here, but you could tell him I said this one. Every school of public health and program public health, I know they have their flavor and they have what they do in their provision for building the skills of the student to be able to make them more impactful and successful in their career decision point. The one area that all public health programs fail. We teach folks how to be great epidemiologists. We teach them how to be great speech pathologists, how to be excellent, behavioral scientists, community planners, all of those exigencies, public administration. We teach them how to do all those things. But from a career perspective, the one thing we do not do, in my criticism, is we do not teach them project management skills. And I explain what I mean by that. You, in your early career professional, yes, you may go into public health prevention, you may have public health education, communications, et cetera. As you grow in your capacity, both whether it's academic or otherwise, your skills and your responsibilities are going to shift. You will now have responsibilities of managing people. So, addressing people skills to that extent is going to be important. Not everyone who's a great epidemiologist is a great manager of people, right? But secondarily, as you increase in your role and responsibility, there's the management of projects, there's a management of grants, there's a management of funded activities and deliverables. And while it may make sense from a disease model to say, okay, I'm doing something on STIs, so I know I need to create my programs to that extent, we're not providing these early career professionals with the skills adequately enough to understand what project management means, how to manage multiple deliverables at the same time, multiple projects, multiple grants, how to address both the budgeting side of that as well as the adjustments that are going to be important to impact the outcomes. And these are things that are wantonly missing from most of the programs that I've seen, where folks have had to augment by going later on to get a PMP certification or hire a different individual, as I've had to do, to hire people to just do project management so that my staff could focus on program content. So driving at that balance, I think, will be significantly helpful in giving the skills necessary, no matter where they end up, for the next generation of professionals to feel that they have the upper leg on the competition.
Oh, that's great. Appreciate that. Thank you. We're going through a self-study for our accreditation, so we may take that into consideration. So last chance for a question. Anyone have, we have 1 more minute left. Anybody have a question?
wanted to comment.
Looks like, yes, Sapna had a question. Sorry,
Okay.
Erica. Yeah. Sapna, she typed it in, I think. So let's see. Oscar,
got
you
it.
want to read it?
I got it.
Okay, yeah.
Yep. American Rescue Plan Act signed in March. You think local health departments would be better do what they're supposed to do, surveillance, ensuring. We hope. In comparison to HCA, yes, because there's the American Rescue Plan, if I could call it this way, and forgive the analogy for those who may not get the reference if you're quote unquote younger. It's like Daddy Warbucks, right? We've been crying, we haven't got the money, now money is supposed to come. We're talking about billions with a capital B. And that's supposed to make it down to both addressing workforce, training, et cetera. Where the difficulty lies, the devil's in the details. It's how this is going to be done. And more importantly, what opportunities do we have not to mess this up? Because if we don't spend the money, if you have like a jurisdiction that only typically had about maybe 34,000 as their entire budget, now they have millions. We got to make sure we properly boost up that infrastructure, both the human as well as the physical infrastructure to address those needs. So there is hope. There is aspiration, and there is bated breath with respect to where we see things coming into play. And for us, we're shifting from a policy perspective to say, what do we need to do to ensure that the investments that are being made, that the way these monies are going to be spent, and the abilities to build, as we would say, implementation science, meaning evaluate what's being done while it's being rebuilt, is going to be important. We can't just say, we're going to slap a Band-Aid on the problem with the money and think, okay, now we have the money, that things are going to go well. Those of you who have seen people who won the lottery know that doesn't always work well, right? So we have to think about that from an institutional standpoint of ensuring that we have proper plans in place, proper reflections and strategic implementation options, so that when we think about what our design elements going to be, our staffing structure going to be, our outcome-based and programmatic entities are going to really preface around, I believe it'll be much better than the ACA. But of course, I don't want to be too optimistic because I'm from New York.
This is great. I can't tell you, Dr. Al, how much this is so well done. We appreciate it. And if you were physically on campus, we would be presenting you with a plaque. Well, I think Cindy may have the plaques in her office, but obviously we can't give you the plaque here, but we will be mailing that to you. I think we have your mailing address. So, but I appreciate this very much. This was spectacular. And so we're going to be.
I think Erica had one last question.
Oh, Erica, go ahead, Erica.
Did you have a question?
Sorry, it was more a comment to what you had just said about program management training. I noticed I'm graduating at the end of this semester. And so I had already started to look at kind of like the landscape for, public health jobs. And I noticed that there were, many jobs looking for program managers, and a lot of them in areas of interest of mine. So I just wanted to say I think that would be a good addition to public health programs to have some experience. That way MPH students can or graduates can jump right into that and start to utilize the skills and the knowledge, and be able to say when they apply for the job, well, I do have some experience. I did, learn these things in program management, and give an edge, competitively, where otherwise there wouldn't be any experience, there wouldn't be any background that would be a reason to hire a graduate for that kind of job.
Exactly.
Well, Erica's also
Erica.
being a little humble, because in our capstone, she's getting project management skills by being the team leader for her e-prep project. So she's asking it for a reason, because she's getting that experience right now, and is looking at how to complement it. So thank you.
No problem.
So I see a couple of people applauding. Amanda, you're applauding, and I know Fatima applauded. So again, we really appreciate your presentation here. For the rest of the people, we will be posting this online once we get this finalized, probably in a day or two. And again, thank you very much, Dr. Alleyne. Oscar, nice job. We appreciate it. Hope to meet you in person sometime.
Thanks so
Definitely.
much
Thank
again
you.
for taking the time.
Yeah, thank you.
No
And you're,
problem.
luck with
Hope it was a good day.
Yes, take care. Thanks.
you were
Anthony.
you're located in Connecticut, right? Is that it? Is that where you're located, or where's your main
No, he's in
office?
Washington, DC.
Oh,
No,
you're-
my office is in DC.
Oh,
Yeah.
okay,
Yeah.
okay.
Yeah,
Very
I
good.
still have a house in New York in Orange County, but yeah, I'm a New Yorker who works in DC.
Okay, well, next time you're up here, stop by. Hopefully we'll be open that you can stop by. So thanks a
do.
lot.
Thanks.
Thanks, everyone. Appreciate it
Bye,
very much.
everybody.
Michael,
Take care.
thank you
Okay,
very much
bye-bye,
for recording this. You can hit the stop now, and we'll